This is Clinical Conversations. I'm Joe Elia. Last week, JAMA published a revision of the definitions of sepsis and septic shock. The 3 papers announcing that change were accompanied by an editorial putting it all into perspective. Dr. Edward Abraham, the Dean of Wake Forest School of Medicine, wrote that editorial, and he's our guest today. Welcome, Dean Abraham.
Great, thanks. Nice to be here.
Would you describe those new definitions as particularly useful?
Yeah, so I think as a general concept, the definitions are useful. They help describe sepsis, septic shock, a new scoring scale to identify patients with sepsis. So that's very helpful. There had been some confusion about how we characterize patients with sepsis and septic shock, and so the new definitions do help with that.
I think you characterized them in the editorial, and the authors of the announcement also characterized them as really important for epidemiological purposes. But those definitions, the new definitions and the new scoring are also going to be useful, is what you're saying.
Yeah, I think primarily from an epidemiologic point of view, they're very clinically based. So the definition for sepsis is evidence of infection, life-threatening organ dysfunction, characterized by an increase of 2 points or more in a sepsis organ failure score called SOFA. Mm-hmm. Septic shock is sepsis with decrease in blood pressure requiring vasopressor support, so support with agents like norepinephrine or dopamine or epinephrine, plus an increase in lactate. So it's helpful for characterization. The new score or the new definitions for septic and septic shock also move away from previous definitions, which had used something called SIRS, systemic inflammatory response syndrome, characteristics, increase in heart rate, increase in respiratory rate, increase or decrease in white blood cell count, increase or decrease in temperature. That was just overly sensitive and unnecessary. And then the definitions also move away from a category that we had in the past called severe sepsis, poorly characterized to just 2 major entities, sepsis and septic shock. So for identification of patients, for epidemiologic purposes, it's helpful and a step forward.
There's also the quick SOFA score,
yes,
which people after it's been tested, probably more fully, is useful at the bedside. And the quick SOFA score is respirations greater than 22 per minute, and blood pressure under systolic blood pressure under 100 millimeters of mercury. And in those 2 circumstances alone, also changed mental status. If you have 2 of those 3, they say suspect sepsis.
That's right. So this is a score retrospectively derived from very large databases. And I should say the use of these large databases is a step forward. Previous definitions for sepsis and septic shock had really just been done by consensus conference without data. It's nice to have some data here. But Quick SOFA was designed, really put together in a retrospective way using those large databases. So there are big gaps in the databases, and the utility of Quick SOFA is for patients outside the ICU, not in patients that are already in a critical care unit, and presumptively identifies groups of patients at higher risk of death during their hospitalization or higher risk of a poor outcome.
Have the new definitions generated any discussion, any hallway discussions with your colleagues?
Well, I think in every healthcare system, sepsis is important. The patients with sepsis consume a lot of resources. They're very expensive, very common diagnosis in the intensive care unit, very common cause of death or associated with a poor outcome. So having new definitions certainly useful. I know on our surgery services, our critical care services, internal medicine services, certainly has been conversation. These articles have really been noticed.
You know, as I was reading your editorial, and it was putting those 3 papers into very good perspective, toward the end of the editorial, You say that sepsis, the way that clinicians think about sepsis, is the way that maybe a couple of generations ago they used to think about cancer, and that cancer was this thing that there wasn't much you could do. You could have a cancer, and maybe there were treatments, but it wasn't that closely studied. And now, with the advent of genomics and other things, those cancers are very carefully and well differentiated. And so one cancer doesn't necessarily look like or even relate to another cancer. And you say that that may be true of sepsis. There may be categories of sepsis that are yet to be discovered. Can you elaborate on that a little bit?
Sure. So the definitions, the present definitions, just like the past one, are for syndrome, clinically defined syndrome. Doesn't say anything about the underlying cellular abnormalities. And I talk about it in the editorial. So sepsis, life-threatening organ dysfunction in the presence of suspected infection. Well, that could be previously healthy young child who gets meningococcemia, meningococcal infection. Could be an elderly patient in his or her 80s, has a lot of underlying disorders, diabetes, cardiovascular disease, maybe Alzheimer's, now gets a urinary tract infection because of their indwelling Foley catheter, and now develops organ dysfunction, yet the definition will say both of them have sepsis. Now clearly their prognosis, their outcome, very likely their underlying cellular abnormalities are very, very different, and it's just not part of the new definitions. So it really leaves us in a situation like cancer was a number of years ago, where not only have we not differentiated between, for example, lung cancer and prostate cancer here, or non-small cell lung cancer and other kinds of lung cancer, but we haven't talked about underlying abnormalities. And the great leap forward in cancer and treatment for cancer has been identification of specific cell types involved, specific receptors that predict response to therapy, specific cellular abnormalities that also predict response to therapy. And we're not there with sepsis and not there with the new definitions either. So I see a really large gap that will need to be covered in the future if we want to develop new therapeutic options for this very important disorder.
There were 15 years between the last revision of these definitions and the current ones. Do you think that the pace of research now that there will be another 15 years before they're revised again?
I hope it'll be a shorter period of time. There's been tremendous numbers of investigations about cellular abnormalities associated with severe infections and the nature, the etiology of organ dysfunctions, not included in these new categories. One would hope relatively shortly that we'll move forward to much better segmentation of these patients, so they can present clinically like this, just like you present clinically with cancer, new tumor in your lungs. But then rapidly the oncologist will move on. They'll biopsy the tumor. They'll look at molecular markers that will help define therapy. And we need to get to the same space in sepsis and should be able to do so relatively quickly. And I would hope we would.
As a final question, what do you think that clinicians should take away from these new definitions? I mean, you say that they have to be validated clinically in the real world, especially in developing countries.
Yeah, so the quick SOFA score has to be prospectively validated. There's some concern that I and others have about the definition for septic shock, which includes a lactate measurement. Lactate's supposed to be above 2. And in developing countries of limited or even moderate resources, they may not be able to measure lactate. So there's some concern about how generalizable these definitions will be on an international basis. Be that as it may, having more clear-cut definitions should raise awareness of sepsis. It's a very important condition. Quick SOFA should help identify patients who are not in the ICU. but are at risk for a poor outcome. So in general, the new definition should help with recognition of the patient's institution of supportive therapy, and there's good evidence that the faster one starts supportive therapy, the better patients do.
I want to thank you, Dr. Abraham, for talking with us today.
It's a pleasure. Thanks for having me.
That was the 196th clinical conversation. I'd love to hear from you and get your reactions to all of this. So please contact me at jelia@nejm.org. We're part of the NEJM group. On behalf of executive producer Kristen Kelly and the Journal Watch crew, thank you for listening.